So
Go.
it's the Vegas test for the MCL. We're going to have the patient supine in this position.
He is a homosexual.
We're going to lift the leg. For this one will be the left leg. We're going to take right hand, grasp it around the tib and fib, down by the ankle. Left hand on the knee. What we're going to do is we're going to push. Push with the left. Bring it back.
Can you put your person to it, please? So we can see. Thank you.
There you go.
Ladies, gentlemen.
That's the Vegas test. Earlier. Left hand around tib and ankle. Right hand, medial side of knee. What we're going to do is we're going to pull and push. Pull with this one, push with the right. Then we're going to lift the leg 30 to 45 degrees in the air. Up here. Then we're going to pull and push. Pull and push.
That's excellent. This is the anterior drawer
Knee needs to be
test.
like this, in a bent position. You're going to sit on the foot, and we're going to take the hands, pull.
Let's see that hand position.
Right here.
Well done. You give it a yank.
Now, on the tibial tuberosity,
As such.
right here, and we're going to sit on the foot, push, push.
Notice he is pushing this time. Very well done.
Calcaneus, grab it, or excuse me,
Other side, right?
gastron, grab it, doesn't matter. I find this the
This is
best
my
one.
right hand.
You need one up high to hold the femur in place, so you don't want it to move. And then you're going to pull the tibia
Oh, that's
forward.
when it's a little twist, right?
Well, it twists a little bit because of how big his leg was. On this one, if you watch, it's not going to twist at all, because I can get my hand mostly around his leg. Either you or somebody else, and then you elevate or distract it. Internal rotation. I'm just putting my knees weight on there so it won't move. So internal, external. External does the MCL, internal does the LCL. And really for that, you're not gonna feel laxity. You're gonna feel pain. That's really what you're looking for in this one. It's not a foolproof way to check how bad the tear is, but it'll tell you if it's sprained. Okay. You either have to grab a calcaneus or the foot like this, because you want to externally rotate or internally rotate the foot as you go into extension. So, external rotation with the valgus force, bringing it into extension. Internal rotation of the foot, valgus force, bringing the knee into extension. Okay.
Guide it down.
Yeah, that's what I'm doing.
That's what I just did.
Like this there, it's just, you have it here, it's like,
It's exactly what I just did.
yeah, I'm not pushing it away.
Simple yet
And it
effective.
bounces home.
The bounce home
Bounce, bounce,
test.
bounce.
Oh, this is absolutely my favorite. I hate this one. So we find the ridge of the knee. Oh, melee will not like this.
Yes.
So you find the ridge, you push down, and really the amount of pressure you're putting on the leg is really about your forearm and your hand
Watch the
weight.
face.
And all you're going to do is ask him to contract his thigh, and the kneecap's going to grind up against the condyles. Ready, set, contract. It actually wasn't too bad. So relax, do it one more time, go. Now you see the difference. The first time I didn't put a lot of pressure on. Second time, he was in a lot of pain. And you felt the crunching of the inflamed tissue underneath the kneecap.
So he has it.
Oh yeah, yeah. Bend this knee. Now on Apley's compression, you don't need to stabilize the femur. It ain't going anywhere. You're gonna push directly down on the calcaneus, so the tibia gets pushed, slammed into that femoral, or into that femur. So when you twist, it grinds the meniscus up against the condyles. If there's a catch, a divot, any type of chip, any tear, you're gonna feel a snap, crackle, pop, or melee is gonna have a ton of pain. But he doesn't have a meniscal tear, so it'll be negative. So we push, we twist internally, and we twist externally. All right, so we do a little external rotation.
Feet on the side of the patient.
You want to be on the side of the patient that you're pushing on. So whichever leg you're compressing, you want to be on the outside of it, the lateral side of it. So internal rotation, external rotation. That's it.
Apprehension test.
Testing for dislocation or subluxation.
Correct. We have the patient supine. We're going to push with both of our hands on the medial side of the patella and watch the patient's face to see if there's a dislocation or subluxation. We have
Scott the
dislocation.
Homo Melee is currently not in any pain,
There we go.
so he is very good to go.
Well done.
Homosexual 1, homosexual 2.
And you want some split tape. One other thing you need,
Come on, turf spray.
what we call a heel lift. You want something to lift his heel up a little bit to really poke out the knee. So as he's doing that, we want to find the kneecap and the tibial tuberosity, and we want to go in between with some pre-wrap. We want to make sure he's stable. Put that leg back a little bit. So you want to go around a couple times, make sure you don't get any hair. You want to take some tape, split tape. We're going to start on the lateral side. You want to make sure not to go over the fibular head. Let's not forget we've got the superficial perineal nerve. We don't want to cause drop foot. We're going to push down so you can see an indentation on the patellar tendon. You're going to go loosely around the back, the popliteal fossa area. Then push right here when you get by the LCL again. Create some tension and push down one more time. When you get by the MCL, lighten up. I'm putting no pressure around the back side at all. You want to go around 3 or 4 times. We're going to stop right there. No pressure. And we're going to stop on the lateral side. Why do we want to stop on the lateral side? Well, if his knee starts rubbing and it's on the medial side, it'll start to come off. On the back side, you get a lot of flexion, guaranteed it'll come off. You have less occurrence of the tape coming off on the lateral side. Now, anything that's not covered by tape, you can simply tear off.
Is that what those bands are for?
That's exactly what those bands are for. Now, this can be 2 tape jobs. We can do it for Osgood-Schlatters disease. We can also do it for patellar tendinitis. Remember, all we're doing is changing the fulcrum point between the tibial tuberosity and the patella. By doing that, we're going to take pressure off of, if it's chondromalacia patellae, the kneecap. If it's tendinitis, the tendon. If it's Osgood-Schlatters, again, we're changing the fulcrum point. So it's going to take the pressure off of the tibial tuberosity. So you will count this as 2 tape jobs, both patellar tendinitis, patellar strap, and or Osgood-Schlatters. 2 separate tape jobs. The patellar straps, you see a lot of the guys in the NBA, or we have several guys during football season, basketball season that wear them. That's exactly what they're doing. Do I put them on soccer players? No, because you slide tackle. They fall right off. Question? Nope. Question? Very simple. This is something anybody can do. Bring some tape on Monday. We're going to practice this a little bit. We really want to focus on palpations and special tests though. All right?